Hello, this is Dr. A with your fourth video in healthcare financing. This is chapter 9 of the 5th edition of Basics of the U.S. Healthcare System for our Intro to U.S. Healthcare class. And this one's going to be kind of all about the government things in healthcare financing. All right. So I'm going to start with a kind of an oddball. It doesn't really fit into any of it. It's not private. It's not private, or at least private health insurance. It's not government insurance. And these are the Samaritan Ministries. So in the late 1980s, Ted Pittenger, the founder of Samaritan Ministries, joined a healthcare sharing ministry and was inspired by the potential for this non-insurance option to provide biblical, affordable health care for the Christian community. So they call this now Healthcare Sharing or Healthcare Sharing Ministry. It is a way that Christians are paying for their health care without using health insurance. When they have a medical need, Samaritan members receive support from other members and pay their health care providers directly from other members. It's really... They all pay money in. It goes into a large pot. It sounds similar than insurance. And then they file a claim and get money to pay or get the services paid for, part of them. There is a membership fee. If you look up like Christian Health Ministry or Christian Healthcare Ministries, you'll see several different options. And then you can kind of explore their websites and they tell you how it works, what it costs, what's covered, etc. So they're looking more and more like health insurance, but they're not the same. And of course, they're nonprofits. Okay, so now let's start with all the government-related things. So we're going to start with the Affordable Care Act and its provisions. So it was passed in 2010. And it eliminated lifetime and unreasonable annual caps or limits on healthcare reimbursement, which would put limits on how much you were able to claim in the lifetime of the policy. It provided assistance for the uninsured with pre-existing condition. Prior to that, insurance companies, like health insurance companies, could deny you coverage if you had too many pre-existing condition because you would be too expensive. You might use their services a lot. And they also prohibited the denial of insurance coverage for children with pre-existing conditions. And then they also extended the coverage for dependents up to the age of 26 years. So you can stay on your parents' insurance for up to age 26. So it also expanded Medicaid. So it expanded Medicaid coverage to nearly all adults with incomes up to 138% of the federal poverty level. So that calculated is $17,774 for an individual in 2021, based on the rates in 2021. They adjust the rates every year of like what that income is. And this provided states with an enhanced federal matching rate for their expansion population. So just to give you a reference, this is the federal poverty level for 2023 and 2024. So for an individual in 2024, it is $15,060. Then you can see a family of 2, family of 3, family of 4 will be $31,200. So this is the federal poverty level. So if you want to know what the expanded one is, the 138% of it is, you would just take that number times 1.38 and you would get the limit. And so you have to be below that income to then qualify for Medicaid. So by expanding the qualification and raising it a little bit, more people got to be covered, because before that you had to be at or below the federal poverty level. So they just raised that to catch more people because, if you look at it, if you're making $15,000 a year in 2024 and let's say now your income that year went to $16,000, well, you're still not making a lot of money and you still probably can't afford health insurance and stuff. And so it allowed for more people to be covered. So in 2022, 38 states had joined, and Washington, D.C. And they've done the Medicaid expansion. 12 have declined. South Dakota is joining the Medicaid expansion in July 2023, which is why it's kind of light blue in here. But they've it's been since they've joined. So if you look again, you should see this map. South Dakota should be in dark blue. So all the countries here in dark blue, all the states here in dark blue have expanded their Medicaid, and all the ones in orange have not. The ACA also established a summary of benefits and coverage requirements. So for all your employers, anybody that offers health insurance, they need to give you these documents. So the summary of benefits very clearly stated what are the benefits and the coverage. And so you could easily compare health insurance plans, what the copays are, deductibles, all the things. Also, there were some co-ops, so consumer-operated and oriented plans. They're member-run healthcare organizations. They must be consumer-focused, with the profits targeted to lowering premiums and improving benefits. So some of those were established. They haven't gone over as well. They've had trouble staying in business. In 2022, there were only 3 in operation in Maine, Wyoming, Wisconsin, Idaho. And I think that it's just not worked out really well for the co-ops. So next big thing was the health insurance marketplaces. So they are run by the federal or state governments, and they are central locations, which is therefore why there are marketplaces, for the healthcare consumer to purchase health insurance coverage, where just like you would go to the marketplace to go get your groceries or whatever, and you can pick from all the different groceries, you can go to the online health insurance marketplace and you can look through all the different plans they have available. So they provide standardized information on the type of health insurance coverage to suit different consumer needs. So everything's standardized, so it's comparable. And consumers are asked to complete an application, and this is just to determine the types of coverage that are available to them based on their needs. The health insurance plans in the marketplace must offer at a minimum the following essential health benefits. So they must offer ambulatory patient services, which is ambulatory means outpatient. So things like physician, services, doctor's offices, outpatient surgeries and therapies and things like that. Emergency services, so pay for visits to, the ER, urgent care, ambulance, etc. Hospitalization, so pay for your stay in hospital. Mental health and substance disorder services, and other essential services like, I'm sure, laboratory diagnostics, which those can fall under ambulatory patient services too. So, some more of the ACA mandates. So, healthcare discrimination against LGBTQ individuals, particularly transgender and gender nonconforming people, is against federal law. Section 1557 provides protection based on race, color, national origin, sex, age, and disability. So LGBTQ protection falls under sex discrimination. This rule applies to facilities that receive federal assistance. So if they receive any kind of federal dollars, which is most of the facilities, I would say, in the healthcare system, they fall under this requirement. So every federal program administered by the DHHS, which is the Department of Health and Human Services, which is the big umbrella organization, that oversees all things that are federal that are related to healthcare, and all their programs under Title I of the ACA. So this includes all hospitals, clinics, pharmacies, laboratories, human immunodeficiency virus testing sites nationally. If they receive a dollar from the federal government, they fall under this requirement. So the individual mandate was written in the ACA of requiring health insurance or pay a fine. So this is where you had to buy, you had to do, get covered, or when you filed your taxes, if you could prove that you had health insurance, then you were going to be fined. And so that was the first legal issue, the first one of the other mandates in the ACA that was contested, and it was disputed in the court system, and it basically ended up falling away, and there are no fines now for not having health insurance. Other legal issues was the expansion of Medicaid in all states was at first mandatory. It was expand Medicaid in all states or lose federal funding. And so instead of they replaced that after the court battles to the federal government would provide incentives to expand Medicaid, but they weren't making it mandatory anymore. And it was one of those things where the states still have their authority, and the federal government can mandate or tell them what to do. And then they also had that all businesses offering contraception as part of health insurance, so that it was contraception was a mandatory coverage. And some businesses pushed back, and so they end up putting a exclusion or things. So basically, they said religious organization could not be forced to provide benefits, medications, or devices that end human life. And so, therefore, they were not required to provide contraception or pay for abortions or things like that. So the ACA CMS Innovation Center, so this is really interesting. So in fall 2021, the CMS Innovation Center set a strategic goal for its next 10 years. They want to transform the health system into one that achieves equitable outcomes through high quality, affordable, person-centered care. And so to do that, you need some ideas. You need some fresh ideas of how to do things better for less money or for in a sustainable way, right? So you could submit kind of a pilot program, a model that you can run and for a certain amount of time. And if it goes really well, then that could become standard of care or a standard practice or a standard reimbursement practice. So the following models are ongoing still currently. So there's 26 accountable care organization models, 6 episode-based payment models, 3 primary care transformation models, 2 Medicaid and Children's Health Insurance Program models, 2 Medicaid and Medicare program models, and 1 director-provider contract models, 14 development and testing of new payment models for different programs, and 5 best practices models. So a bunch of them that are being tested. So now let's dive into government insurance. So we're going to start with Medicare. So Medicare was created in 1965 and signed into law by President Lyndon Johnson. The CMS, or Center for Medicare and Medicaid Services, has oversight of Medicare. In 2022, there were 65 million Medicare enrollees. So Medicare Part A is primarily financed from your payroll taxes, and it is considered hospital insurance exclusively. So that is how it started, because hospitals were expensive, so the government decided to provide Medicare Part A to the elderly to offset the cost of hospitalization. So your employer and employees contribute to the Social Security Medicare funds, and Medicare is health insurance for individuals who are 65 years or older, and some individuals who are younger than 65 if they have a designated disability or if they have kidney disease. And so you basically pay into the system your entire working life, and then when you turn 65, you should be able to receive the benefits of Medicare, at least Medicare Part A, which is hospital insurance. But if you want more, you would have to enroll in Medicare Part B then. So that was the next step that was added, and it is a supplemental health plan to cover physician services, because Medicare Part A does not cover physician services, and that was still a cost to the patients, and that it was getting higher and higher and hard to manage. So Medicare Part B covers 2 types of services: the medically necessary services. This is services or supplies that are needed to diagnose or treat your medical condition and that meet accepted standards of medical practice. And then they also cover preventive services or healthcare to prevent illness. So that's what Medicare Part B is. So you can get a wellness checkup as part of your Medicare Part B. And so you have to know that Medicare covers less than half of total healthcare costs for their enrollees, which leaves them, again, with substantial out-of-pocket expenses. So to cover these expenses, Medicare enrollees can receive additional coverage from Medicaid. So again, if they meet the income threshold, if they're below the federal poverty level or the expanded federal poverty level. So they can, if they're eligible, then they can be dually enrolled. They could enroll in Medicare Advantage, which is Medicare Part C. We'll talk about that. It's the managed care version of Medicare, which can then provide supplemental coverage, or maybe if they have their employer-sponsored retiree insurance, so their workplace allows them to continue their coverage into their retirement age. That means they still have to pay premiums though to that, for that coverage, but you can couple that then with Medicare to increase your coverage. Or you could purchase supplemental insurance policies from private insurance companies, which are called either Medigap or MediSup or MedSup policies. So your MedSup plans will cover co-payments, deductibles, and co-insurance, which can be very expensive. Medicare has created 10 MedSup plans that vary by state. And then you have Medicare Part C. And so this is called Medicare Advantage. So these Medicare Advantage plans cover all Medicare services and also vision and prescription care. So we're talking about hospitalization, we're talking about physician visits, doctor's visits, etc., and even prescription drugs, which we're going to talk about next because that's Part D. So Medicare cost plans are a type of HMO plan, and they have similar rules to the Medicare Advantage plans. The CMS reimburses managed care organization on a preset monthly basis per enrollee based on a forecasted budget. The reimbursement rate is based on the reasonable cost of providing these services. So Medicare Part D. The Medicare Prescription Drug Improvement and Modernization Act of 2003 authorized Medicare Part D to produce the largest additions and changes to Medicare in a long time. So the tax revenues of the federal government support the majority of the program costs. Its purpose was to provide seniors with relief from high prescription costs. Like Part B, it is a voluntary program because enrollees do pay a premium for coverage in Medicare Part D. So Medicare Part C has Part D benefits rolled into the program. So if you do the Medicare Advantage managed care option thing, your Part D should be rolled into it, and you're covered for everything. Private health insurance companies also contract with Medicare to provide these Medicare Part D services. PACE, so this was also authorized by the Balanced Budget Act of 1997. It is the program of all-inclusive care for the elderly. So it's a comprehensive healthcare delivery system. It's funded by Medicare and Medicaid, and oversight is provided by CMS. So again, Medicaid, you have that income eligibility. But a PACE program is able to provide an entire spectrum of continuum of care and services to seniors with chronic care needs while maintaining their independence in their home for as long as possible. So the idea of PACE is to not have to put the seniors in a nursing home. It's to keep them in their homes, in their communities. Locally, we have a program that's called Total Life, and they offer rides to physician visits. They also can have visits on site. There are exercise programs. There's so many things that can coordinate, meal plans. They can coordinate all of these benefits so that it's all centralized in one location. It's easier to keep up with. You have a team that follows the patient, that knows what's going on with them. And so as of 2019, there were 130 PACE programs operational in 31 states. Workers' compensation. Workers' compensation protects both the employer and the employee if a job-related injury or illness occurs, or the employer is financially liable for employees who become injured or ill as a result of working conditions. So it is a state-administered program. Employees are eligible for this program for medical care, death, disability, and rehabilitation services. Most employees will receive 66%, or about 2/3 of their earning, which is tax-free as an income while they're disabled or they're off work because of the injury or illness. Workers' compensation programs are funded by the employer, which either contracts with a commercial insurer to buy the workers' compensation insurance, or if they have the funds, they can just self-insure. If their experience rating is high, meaning the likeliness of a worker getting hurt is high, their rates will be high. Expert estimates that 1 of 20 occupational disease victims receives workers' compensation benefits, and that 1 of 100 occupational disease victims receives workers' compensation benefits for occupational cancer. TRICARE. So as the active duty numbers has increased, a special Medicare program called TRICARE was developed to best respond to the growing needs of active duty and retired members. So the more active duty members you have that are there for 20 years or more, the more of them you'll have retiring. Therefore, that population grows and the needs increase. So TRICARE can be accessed by both active duty and retired service members and their families. It combines the healthcare resources of the uniformed services with networks of civilian healthcare professionals, institutions, pharmacies, and suppliers to provide access to high-quality healthcare services while maintaining the capability to support military operations. Also, TRICARE is now merging and really working in conjunction with the VA to expand their services. So there's some collaboration going on between the two entities because it serves similar population. I understand the veterans are for veterans, not active duty military members, but still there's some collaboration going on currently. And then lastly, we have our Veterans Health Administration. It is America's largest integrated healthcare system. It provides care at 298 healthcare facilities, including 171 medical centers and 1,113 outpatient sites of care of varying complexities. These are your VA outpatient clinics. The system serves 9 million enrollees, veterans, each year. Patient advocates are highly trained professionals located at every medical center who can help resolve patient concerns about any aspect of their healthcare experience with the VA. So this wraps up the end of kind of all the governmental things related to healthcare financing. We got one more video to close this out coming up next. See you there.